Hey guys, Dr. Linville here. You thought you got rid of me. Sorry. I'm still here, and we'll be going over post-op lectures all this term. And we're going to be looking at, of course, the hip first, then the knee, then the foot and ankle complex. And this is probably the longest lecture of them all. Maybe the ACL lecture is pretty long as well, but the hip arthroscopy lecture is one of the longest. And that's because there's a lot of emerging research and surgical techniques on this procedure. Now, as this is the first lecture of this series this term, I want you to realize that these postoperative lectures are more good to know information and maybe not need to know right now for musculoskeletal. Right, musculoskeletal, we want to learn how to evaluate and examine a patient's lower extremity and kind of come up with a game plan on how to treat it. As you guys get more seasoned and you go on clinical rotations, these lectures will become more important as you are seeing patients with post-operative conditions. So without further ado, let's get into this, and then as we go, I'll tell you things that you might need to know now for test purposes and what you might want to know in the future but might not be as important at the current moment. So introduction. The hip labrum has many functions. It's involved in shock absorption, joint lubrication, pressure distribution, and aiding in stability. The etiology of labral tears includes trauma, femoroacetabular impingement, also known as FAI, capsular laxity or hip hypermobility, dysplasia, and of course, over time, degeneration. Labral tears present with anterior hip or groin pain, and less commonly buttock pain. Frequently, there are also mechanical symptoms including clicking, locking, and giving away. The most consistent physical examination finding is a positive anterior hip impingement test. That's what we would look for in a labral injury. Now, if we get into hip arthroscopy, because of the anatomical structures of the hip, arthroscopy is a very technically demanding endeavor. Appropriate patient selection is of paramount importance to a successful outcome after hip arthroscopy, and the number of hip arthroscopy procedures performed in the United States by the American Board of Orthopedic Surgery candidates increased 18-fold from 1999 to 2009, and that's due to a great acceleration of technology and arthroscopic techniques. So arthroscopic hip procedures can include labral repair, refixation, reconstruction, acetabuloplasty, femoroplasty, microfracture, chondroplasty, loose body removal, synovectomy, ligamentum teres debridement, iliopsoas release, capsular closure, gluteus medius and minimus repair, and piriformis release or sciatic nerve decompression. We will be focusing on the top three, the labral repair, acetabuloplasty, and femoroplasty in this lecture. And just to give you a brief rundown, labral repairs are when they actually suture and fix the labrum that's torn. If you think kind of like a meniscus or the labrum in the shoulder, very similar type of procedure. And acetabuloplasty is when they basically trim bone from the acetabulum to create joint space, and then a femoroplasty is when they trim back bone from the femur for increased joint space. And the acetabuloplasty is usually due to a pincer lesion, which we'll go over later, and the femoroplasty is how we would treat a cam lesion, which we will also touch on. So demographics, most common indicator is a painful, functionally limiting degenerative change of the articulating joint surfaces of the hip. Potential indicators for arthroscopic intervention include, but are not limited to, symptomatic tears of the labrum, capsular laxity and instability, chondral lesions, osteochondritis dissecans, if you guys remember that one from the elbow, ligamentum teres injuries, painful snapping hip syndrome, and the presence of loose bodies. Pain generators of the hip, this is taken from Tibor et al. In 2008. These are things they came up with that are likely causing hip pain, anatomically speaking. If you think about a pathoanatomical model, you have your intra-articular, your extra-articular, and your hip mimickers all can cause pain in or around the hip joint. The ones with the stars next to it are the ones that can be treated with arthroscopic surgical procedures. So it's a good slide to know. Preoperative special tests. So you have your examination evaluation with the patient, and you finally get to special tests with some things that might rule in labral pathology or femoral acetabular impingement. And then while we're on that topic, femoral acetabular impingement is kind of like a bucket term, just like shoulder impingement is, right? There's several different types of impingement of the shoulder. You have primary and secondary impingement. You have impingement that's, we're talking about the shoulder now, impingement that's called by bony approximation. You have impingement that's called by bursal irritation, right, or biceps tendon irritation. Very similarly in the hip, you can have bony impingement that is creating pain. You can have the labral tissue is getting pinched, which causes impingement. You can have bony overgrowth. There are a lot of different reasons for pain in the hip. So these will help you rule in what we would call femoral acetabular impingement, which may suggest a labral tear or a cam or pincer lesion. So the special test we look at is the Faber test and the Fadir test. Faber stands for femur, abduction, and external rotation, flexion, abduction, external rotation. And the Fadir is flexion, adduction, and internal rotation. I'm sure JD will go over this with you, Dr. Fields will go over it with you in the lab portion. The log roll test, the Scour test, pain with prolonged sitting with hip flexed at 90 degrees, pain with active hip flexion greater than 90 degrees, and then pain with squatting. So you see a common theme here is that flexion and internal rotation irritate people's symptoms. If you look at the table 3 here, potential findings of patients with labral tears or hip instability, there's also reports of groin pain, accompanying low back pain or SI joint pain, difficulty with activities requiring hip rotation, subjective report of weakness and decreased stability, restricted range of motion, painful clicking sensation, difficulty and pain transitioning from a sit to stand position, and difficulty with prolonged sitting. Now we're going to get into imaging of the hip. And here's where this is a nice to know set of slides. We'll be going over the center edge angle, Klein's line, what a pistol grip deformity is, looking at the alpha angle, what a crossover sign is, and what an ischial spine sign is. These are all ways that physicians, and even us as physical therapists, if we have access to imaging, can help determine what a patient is going through. Now, we're not diagnosing them with anything because there's probably millions of people with these radiographic findings that don't have hip pain. But in the presence of pain, discomfort, positive special test, and imaging, it's fairly well known that these might be the symptoms they are experiencing. So if we move on, again, these are nice to know information, and as you grow as a clinician, maybe in a year or two, post-grad, you might want to reference these and see, if you have imaging of a person's hip, kind of take it into your own hands and figure out what they might be going through. The first one we'll look at is called the center edge angle. This provides useful information after the age of 5 years old for hip dysplasia. So I want you to look at the pictures on the right. The top picture shows a normal hip. If you look at the center of the femoral head and the rim of the acetabulum, that's a good ratio or angle rather, center edge angle in a normal healthy adult. If we go down to picture A and also picture B, it's the same hip, they're just looking at two different angles. You can see how small and short that or acute that angle is in picture A compared to the red dotted line at the top. That would indicate hip dysplasia. So as we move on this lecture, there we go. Angle, the center edge angle is the angle formed by a line drawn from the center of the femoral head to the outer edge of the acetabular roof and a vertical line drawn through the center of the femoral head. The angle, if it's greater than 25 degrees, is considered normal, and an angle less than 20 degrees indicates severe dysplasia. Klein's line is another thing we can see on imaging, and it describes a SCFE, or a slipped capital femoral epiphysis. Klein's line describes a line along the superior edge of the neck of the femur, and the line should normally intersect the lateral part of the superior femoral epiphysis, as you can see here. Here's the the superior edge of the neck of the femur, and here's the lateral part of the superior femoral epiphysis, and you can see how it transects the femoral head here. This one, the femoral head, is inferior to Klein's line, which might indicate a SCFE. A pistol grip deformity is indicative of a cam lesion or a cam deformity. It's also known as, or having an increased alpha angle. The reason it's called a pistol grip deformity is because you can see how in a normal hip looks this way, and then a pistol grip, the femoral neck is thickened, making it look more like the butt of a pistol. Here's another indication of that. Now what happens is the alpha angle, well, basically, let's just put it this way. Your femoral head should create what looks to be a 360-degree circle. There should be no bony projections off of this. It should look fairly reasonable like this. In a cam lesion, what we notice is that as we draw our circle, there's bony overgrowth. There's offset, as they would call it, bony overgrowth that extends past what the normal 360 degrees looks like. So it's more oblong circle. This projection of bone, as the hip rotates up, will make contact with the lip of the acetabulum, creating pain or labral pathology. This also can become painful itself. If we look at the x-ray here, you can see that the femoral head is not very circular in appearance. It is more oblong shaped. This right here is what we would call the cam lesion, this portion of bone that looks like it's now undergone Wolff's law and has bony overgrowth. This is what we call pincer lesion, and I'll show you why on the next slide. But a pincer lesion is when the acetabulum has bony overgrowth from repeated bony approximation here. There we go. A crossover sign. This is where I might lose some of you, and that's okay. Remember, this is nice to know information. When you look at a picture of the hip on an x-ray, because a hip is not looking at three-dimensional structures, it's looking at two-dimensional structures, you will get overlap of images if you have, let's say you have your hip is in front, your femur is in front of the posterior portion of your acetabulum. What we want to look at here is, and this might be a good time when you're studying to take a model of the pelvis and examine it. When you look at the pelvis straight on, you can see the acetabular rim, and what it should look like is the rim and the acetabulum should face inferior, anterior, and lateral. When people get into trouble is when the rim points inferior, lateral, and posterior. And if it points posterior, we would call that retroversion of the acetabulum, and that would mean that the anterior portion of the acetabulum has bony overhang in the front part. This can cause impingement if there's too much bony overlay in the front. So let's get into this. A crossover sign is when you notice on an x-ray that the anterior line crosses the posterior line, and this is looking at the rims of the acetabulum. The black line would indicate the anterior acetabular rim, and the white line indicates the posterior acetabular rim. And as you can see, they cross over, and if you can picture this two-dimensional picture in a three-dimensional model, you would have more bony overhang in the anterior portion of this person's hip. Now, this is not anatomically abnormal, but it may lead to impingement symptoms because there's more bony anatomy in the front of the hip. This is what a normal x-ray, quote unquote normal, should look like. The lines do not transect each other. So if we go over what my slide says here, in the retroverted condition, the superior aspect of the acetabulum is tilted posteriorly. On the AP, anterior to posterior x-ray, in a normal acetabulum, the anterior rim of the acetabulum should always project medial to the posterior wall. It's a better way to put it than what I said. In acetabular retroversion, the anterior rim will project lateral to the posterior wall in the superior aspect of the acetabulum. So again, we go over this. I think I said this backwards before, but the white is going to be your anterior rim of the acetabular. And you can see how the anterior rim projects lateral to the posterior wall. So if this is medial and this is lateral, the anterior rim projects lateral to that. So I mixed it up earlier, so I apologize. The black is the posterior rim, the white is the anterior rim. The ischial spine sign is when you can notice the ischial spine on radiographs. So what you want in the the pelvic rim here is a nice smooth line, meaning here we would have the ischial spine behind all this. If there is an ischial spine sign, it might indicate as well that there's a crossover sign. This is looking at almost everything in that we've gone over. The circle is looking at your basically kind of your alpha angle, as we mentioned before. Here is the anterior rim. Here's the posterior rim. And you can see this crossover sign here, this bony overlay, and they have an ischial spine sign. So this might indicate that this person is dealing with impingement. So if I haven't lost you yet, hopefully I won't the rest of the time. We're almost done with some of this stuff here. The cam versus pincer lesions. A cam lesion is a bony overgrowth of the femoral head. There's increased prevalence in men. A pincer lesion is a bony overgrowth on the acetabular rim, and that's increased prevalence in women. I'll have you pause it here, read through figure 3, and you can see why and how a cam and pincer lesion comes to be. Here's another picture that I like because they highlight the areas where the lesions are occurring. So here's a normal hip, nice anatomy. Cam lesion, you can see the bony overgrowth on the femoral neck. Pincer lesion, you can see the bony overgrowth on the acetabular rim, and a lot of times you'll see it on both. Here's a mixed, as we just said. Here's another way a cam lesion can occur, or just another schematic. Repeated hip flexion or internal rotation. The neck of the femur can abut the labrum and the acetabular rim, creating Wolff's Law bony overgrowth. Similarly, with a pincer lesion, the same thing can occur. So for these patients, surgery might be an indication because they have repeated pain, mechanical symptoms, and dysfunction. The right candidate must be chosen for successful outcomes. Patients who do well are showing physical evidence of hip joint pathology. There's radiographic evidence of intra-articular damage. They might have had trauma, previous surgical interventions, absence of significant soft tissue pain, tenderness, and restriction, presence of adequate hip strength, realistic expectations, and a history of compliance. Surgical techniques. Patient positioning. So, I have two different pictures here. Arthroscopic surgery is not done very often in the hip, and the reason is that it's very hard to train to be an arthroscopic hip surgeon. There's a lot more going on in the hip and around the hip than there is in the shoulder. There's a lot more anatomy, there's a lot different styles of tissue, and there's a lot thicker tissues to get down to the hip joint itself. It is not an easy surgical procedure to learn, and I hold hip surgeons, arthroscopic hip surgeons, in high regard. So, patient positioning for hip arthroscopic surgery. This could be a labral repair. This could be an osteoplasty, which we mentioned before. You typically have them in the lateral decubitus position, sometimes supine, but that's the surgeon's preference. If there's a specialized surgical table used to apply traction and position the leg. So what you can see here is that they've tried to pad this patient very well, and they're with that boot on, they're applying traction to the joint to give it some joint space. If you look in the back of this picture on the left, you'll notice this big thing here that looks like a letter C. That's called the C arm, and that's for fluoroscopy. Fluoroscopy is real-time radiographic imaging that helps surgeons determine where their surgical instruments are compared to bony anatomy. This is an overview picture where you have the person in a supine position. This is the C arm. If you can imagine, that's like a big letter C. You're just looking at the top of it. And there's monitors, of course, that they're looking. And these are the surgeon, scrub nurse, and all that stuff. So a lot going on in the hip. Here's the difference between hip surgeries and shoulder surgeries in terms of arthroscopic. And this goes for knee as well. The arthroscopic camera in hip surgeries, and this is why it makes it so difficult to become an arthroscopic hip surgeon, is because there's a different degree of arthroscopic viewing window. So arthroscopic instruments can either come in 0 degree distortion, 30 degree, or 70 degree. If you look at the picture on the right, here, straight on, the arthroscopic camera is here. That's 0 degrees. What you're looking at is probably what it looks like. This is a little more wide and more distorted image because it's angled, but it allows them to see more in this window than straight on. The good thing about this is that there's no distortion, but you have to point your camera right at it. The 30 degree, you can point near it and you can pick it up. And then the 70 degree, if you see the window of what you're looking at here, opens very, very wide to allow you to get a lot of observation when you're in someone's hip. The problem is that it distorts the image, and you can, like a fisheye lens, right? This would be more of what a 70 degree, or excuse me, a 30 degree camera would look like. Everything's closer together. You can see that here. And then this on the right is more what a hip scope camera would look like. So, I mean, if you just take, for instance, this gentleman here and compare it to this gentleman here, they look completely different. So it takes a trained eye and a lot of practice to know how and where to probe your instruments to perform the procedures because of the distorted image that you're seeing. And this is why arthroscopic hip surgery is a difficult thing to learn and master. Potential complications of hip surgery are pudendal and lateral femoral cutaneous neuropraxia, iatrogenic labral perforations and tears, instrument breakage, incomplete recession, hardware and instrument failure, and iatrogenic injury to chondral surfaces. The lateral portal placement is the most important one because could be injury to the lateral femoral cutaneous nerve, and of course this gives you sensation to the kind of the anterolateral portion of your hip, right? It's not a motor nerve, but it is one that will mess with your sensation. Outcomes of arthroscopic hip procedures are actually very good. The patients I've seen with this procedure usually do extremely well. Systematic review by Kahn et al. Identified improved clinical outcomes after arthroscopic intervention for FAI at both the short and midterm as assessed by a variety of functional outcome scores and studies. The surgical procedure. I will not be reading this slide. You can pause it and you can look at this if you'd like. But it is going to be explained in this video by Dr. Jason Folk. He talks about FAI, and then I believe there's a video of him doing a labral repair, acetabuloplasty, and femoroplasty. And that's what we'd like you to know now. Remember, the acetabuloplasty is for a pincer lesion. The femoroplasty is for a cam lesion. And a labral repair, of course, is to repair the labrum. Now we'll get into physical therapy considerations following hip arthroscopic labral repair. Phase 1 is your pain control and controlled range of motion phase, weeks from 0 to 4. Your goals here are tissue protection, decreased pain and inflammation, increased range of motion with restrictions per the surgeon, prevent muscle inhibition, and promote correct muscle firing patterns. Here's an example of some exercises that you can do and some precautions that you have from Pro Axis Physical Therapy, now ATI in Greenville, South Carolina. This is where I did my residency. So we had them do touchdown 20% with flat foot weight bearing for 3 to 4 weeks. Dr. Folk will make a decision at first post-op appointment if you'd like them to progress. You want to avoid flexion past 90 degrees and avoid external rotation of the hip for greater than 30 degrees for 2 weeks. This phase, 0 to 4, is your protected mobility phase. You can pause it and look at this if you'd like to. Post-op week 1, outpatient orthopedic setting. Some surgeons have patients start at 2 weeks. You want to observe your patient's pain tolerance, muscle guarding, and gait mechanics. They should be using crutches. Remember, they're partial weight bearing. Are they tight or lax? What's their normal resting state? You might want to use the Beighton index. This may help drive your treatment priorities. If you have someone that's very hyper lax naturally, aka double jointed or whatever you want to call them, then you're going to work more stability exercises. You might have someone who's tighter and in a resting state, and you're going to work on more mobility drills. The main goal, though, is to get the glutes firing. They might be in a post-operative brace. This is not typically indicated for labral repairs unless there's something special going on, or they might have a concomitant gluteus medius repair or something of that nature. These braces are used to prevent hyperextension and abduction. Surgical operations which have bracing include anterior capsular repair, proximal rectus femoral repair, proximal sartorius repair, and anterior labral repair. Postoperative patient education, you want to educate them on their weight-bearing status. You don't want them to elevate the leg. Flat is best, actually. And really, you want them to do 2 hours of prone positionings per day. That doesn't mean they have to do 2 hours in a row, but they should be able to accumulate 2 hours of prone positioning throughout every day. This is to prevent hip flexor tightness if they're sitting all day. You're going to avoid straight leg raise into flexion. That's important. Why do you think that is? I'm going to let you guys figure that one out in class. And then, of course, you want to tell them about their range of motion restrictions. The precautions, as you can see here, this is a great slide. Labral repair, weight bearing, 3 to 4 weeks, toe touch weight bearing. Microfracture, non-weight bearing for 6 weeks. Osteoplasty, partial weight bearing from 0 to 4. And a capsular repair, toe touch weight bearing for 3 to 4. So pretty much after every arthroscopic hip surgery, there's going to be weight bearing precautions. So you just need to know that to help your patient. There's also range of motion precautions, so look over that one as well. All right, this is a slide that kind of helps someone determine what restrictions, if they have high-level restrictions or not, based on the surgical technique. So if it's a structural repair or bony contouring, if you choose no, then you only have one option. That's debridement or loose body removal. The restrictions are then based on the symptoms until they normalize gait. There's really not weight-bearing restrictions here. They're just cleaning it up. They're not fixing or repairing anything. If they do have structural repair, bony contouring, that could include the following procedures: acetabuloplasty, femoroplasty, labral repair, capsular repair, or microfracture. And it goes from top to bottom how many restrictions they might have. Capsular repair and microfracture have significant restrictions, whereas something just like an acetabuloplasty has minimal restrictions. Phase 1 intervention ideas. You're going to try day 1, gait training, isometrics, upright bicycles, fine, as long as there's no resistance. And you're going to instruct their caregiver on how to perform manual circumduction of the hip. Also in phase 1, you're going to try to do prone, supine, and sideline glute exercises, the upright bike, and manual therapy. This is where you're going to do your joint mobilizations. Here are some ideas for phase 1. You can pause it here and look at from left to right. I've listed out the exercises. Criteria for progression to phase 2. They want to have minimal palpable swelling. You want to progress them to full weight bearing. Their range of motion needs to be greater than 75% of the uninvolved side. Their pain has to be less than 3 out of 10 on the visual analog scale. Their pain is 0 out of 10 with all phase 1 exercises. And muscle activation and firing patterns are normal and without compensation. Phase 2 is from weeks 5 to 8, and that's your muscular endurance and motor control phase. Phase 2 goals, you're going to normalize gait, restore full range of motion, improve neuromuscular control, muscular imbalance, and proprioception. You want to initiate functional exercise to improve movement patterns with emphasis on maintaining lumbopelvic stability. Phase 2 keys are glute med and glute max retraining, psoas retraining, pelvic stability, and lumbopelvic rhythm. Here again is from a protocol. You can pause it here and look at this if you'd like to. Here's phase 2 intervention ideas listed out as exercises. This is when I would start getting them more into a quadruped position. Also have them do more standing exercises, and finally start loading them on the leg press. Criteria for progression to phase 3. You want pain-free and symmetrical gait pattern, full range of motion, no joint inflammation, muscle irritation, or pain, normal muscle activation and movement patterns, single leg balance for 1 minute with a neutral pelvic alignment and no compensatory trunk lean or Trendelenburg. Hip strength. You want greater than flexion greater than 60% of the uninvolved side, and other planes greater than 70% of the uninvolved side. Phase 3 is your strengthening phase, weeks 9 to 16. So if you think about months, that's months 2 to 4. You want to restore muscular strength and endurance, optimize neuromuscular control, balance, and proprioception, restore cardiovascular endurance. And then the keys to phase 3 are to ensure the patient has met the criteria to begin running, plyometric and agility drills, and that's going to be seen in phase 4. Good lumbopelvic control with all movements. Your progression to running, their criteria. Here's what I do. They have to have Y balance equal bilaterally. They have to be able to perform a single leg squat test with a sport cord or resistance band for 1 minute and 30 seconds without fatigue and good control. They have to do jumping on the shuttle leg press with pain-free and good eccentric control. They have to have alternating hops on the ground, ability to have pelvic stability with hip extension, timed like a prone plank with hip extension, and functional movement screen needs to be equal bilaterally. The biggest ones that they'll have a problem with are the hurdle step, the inline lunge, and quadruped. Phase 3 intervention ideas. Now we're starting to get them loaded, and we're starting to do more single leg activities. You can see the ones we have pictured here. Criteria for progression to phase 4. Hip strength has to be greater than 70% of the uninvolved side for flexion, and the other planes need to be greater than 80%. Lower extremity Y balance test needs to be equal bilaterally. The functional movement screen needs to be greater than 14. 14 is the cutoff. It's scored out of 21 points. It shows a clinician how well someone moves. And there's different thoughts on the FMS, but it's pretty good to start building objective criteria for moving on to the next phase. They have to pass the hip sport cord test. This is a test that looks at multi-directional movement against resistance. They have to demonstrate initial agility drills with proper body mechanics. They have to have good eccentric control of glutes and quads and avoidance of excessive dynamic knee valgus. At 4 months, you can begin plyometrics if they've met their goals. This is to restore power and speed, ensure proper landing mechanics, ensure an athlete can handle all demands of their sport. I want you to see the Davies article. I'll try to upload that. That's on lower extremity and upper extremity plyometrics. I think I uploaded it last course. You're going to look at the LESS test, which is the landing error scoring system test. And you're going to progress them in terms of intensity, multiplanar movements, resistance, block practice towards randomized practice, change of direction, and reaction time. Let's see if these videos work. This is of the landing error scoring system. And they might not, and that's fine. Well, let's move on. The landing error scoring system looks something like this. Someone will stand on a box that's the height of their tibial tubercle. You will measure then from their their hip pointer all the way down to the floor. I should say your greater trochanter down to the floor in centimeters. You will measure that distance, their hip or their leg length, and you will have them jump off the box to a piece of tape on the floor that is that distance away from the box. So they're jumping from the box to a distance that's the length of their leg away from them. They're going to land from the jump and then complete immediately afterwards a vertical jump, landing a second time. What you're looking for in this test is their hip angle, their trunk angle, their landing mechanics, their power absorption and distribution, and their motor control. Here are some things that we score. The lower the score, the better. And to pass this test, you have to get less than 5 points. You're going to look at when they land their stance width, their maximum foot rotation position, their initial foot contact, whether they land with both feet at the same time or they land one foot and then the other hits the ground. Their maximum knee valgus angle, so you don't want to see their knees caving in. Amount of trunk flexion, lateral flexion or forward and backwards flexion. Initial landing of the feet. Are they landing toe to heel, or are they landing heel to toe, or are they landing flat-footed? Amount of knee flexion displacement, amount of trunk flexion displacement, total joint displacement in the sagittal plane, and overall impression as a clinician. This is one that you guys should probably practice. It is one that you will do with ACL and knee patients as well. Phase 4 intervention ideas, you can see here, basically nothing's off limit. Now they're doing strength and conditioning work as long as they're not having pain and discomfort. Here are some other intervention ideas for agility work. And these can be done, of course, with knee and foot and ankle patients as well. So it might be a good reference slide for those patients. Phase 4 is week 20 or more, so 5 months. This is your return to sport phase. Your return to sport testing must pass all functional discharge testing cleared by the physician to return to sport and able to perform sport-specific drills at full speed. Here's basically the timelines for phase 3 and 4. And then finally, you return to sport. You have graded exposure and integration back into your sport, and you meet your goal. Thank you, guys. This has been Hip Arthroscopic post-op lecture, and with good to know and need to know information. If you have questions, please email me, linvillebr@gmail.com. And I look forward to continuing helping with your education in your physical therapy career, and I'm always available to you guys if you need me. Thanks.